Welcome back. I am Dr. WAFAEY BADAWY. I'll be talking about thyroid nodules, cytologic clinical correlation, part 2. I would like to remind you that the BETHESDA system classifies thyroid FNA-C into 6 categories. Each category of the BETHESDA is linked to a malignancy risk and has a recommended clinical management. Malignancy risk according to BETHESDA system. Non-diagnostic or unsatisfactory, category 1, it is 1% to 4%. Category 2, benign follicular nodule, 0% to 3%. Category 3, ATYPIA of undetermined significance, from 5% to 15%. Category 4, suspicious for and follicular neoplasm, 15% to 30%. Category 4 also, suspicious for HÜRTHLE neoplasm, 15% up to 45%. Category 5, suspicious for malignancy, 60% to 75%. Category 6, 97% to 99%. Recommended clinical management. Non-diagnostic or unsatisfactory category, repeat FNA after 3 to 6 months with ultrasound guidance. Benign follicular nodule, clinical follow-up every 6 to 18 months for at least 3 to 5 years. ATYPIA of undetermined significance, repeat FNA after 3 to 6 months. Suspicious for a follicular neoplasm or its subtype HÜRTHLE neoplasm, surgical lobectomy. Suspicious for malignancy, total thyroidectomy or surgical lobectomy. Malignant, total thyroidectomy. It is very important to remember that indeterminate thyroid nodules correspond to the categories 3, ATYPIA of undetermined significance, follicular lesion of undetermined significance, and category 4, suspicious for a follicular neoplasm of the BETHESDA system for reporting thyroid cytopathology. Their malignancy risk is 5 to 15% and 15 to 30% respectively, imposing surgical treatment for definitive diagnosis. Intraoperative frozen section. Intraoperative frozen section analysis of the thyroid nodules is used to avoid a 2-stage thyroidectomy. Frozen sections are useful in guiding the preoperative management of BETHESDA category 5 nodules, that is suspicious for malignancy, especially in the subset with papillary cancer, allowing 1-stage total thyroidectomy. Intraoperative frozen sections of indeterminate thyroid nodules, such as suspicious for a follicular neoplasm and HÜRTHLE neoplasm and follicular variant of papillary carcinoma, are of little use and not recommended systematically. Frozen section biopsy is not necessary when FNA biopsy gives a malignant or benign diagnosis. Why are patients with suspicious for a follicular neoplasm and suspicious for HÜRTHLE cell neoplasm not candidates for frozen sections? Frozen section is discouraged in the evaluation of these nodules, BETHESDA 4 category, because a careful and comprehensive meticulous evaluation of the tumor capsule is mandatory in order to visualize a capsular or a vascular invasion permitting to make the diagnosis of malignancy. However, this assessment is only possible on permanent section, that is paraffin blocks. Frozen section can jeopardize the detection of signs of capsular invasion on final pathologic examination because freezing results in fragmented thyroid specimen. Frozen sections lead to the prolongation of the operating room time and is source of additional costs. Frozen section wastes resources and rarely gives useful diagnostic information in the BETHESDA category 4. Finally, the decision for completion thyroidectomy should be determined by the final pathology. What should be done for non-diagnostic FNA? A repeat aspiration with ultrasound guidance is recommended for non-diagnostic cases. The repeat FNA is diagnostic in 50% to 88% of cases, but some nodules remain persistently non-diagnostic. Because about 10% of persistent non-diagnostic nodules are malignant, excision is often considered. What should be done for a benign follicular nodule? Patients with benign thyroid cytology are generally followed clinically with periodic physical examination supplemented by ultrasound in some cases. The physical examination is for palpable nodules, thyroid asymmetry, abnormal cervical lymph adenopathy, the rate of growth. Follow-up is carried at 6 to 18 month interval and for at least 3 to 5 years following the initial benign diagnosis. Repeat FNA is recommended for nodules showing significant growth, developing ultrasound abnormalities such as irregular margins, microcalcifications, and intranodular hypervascularity. When is lobectomy considered in benign follicular nodule? A minority of nodules with benign cytology, approximately 10%, undergo surgery. Lobectomy is considered in compressive symptoms if the patient or parent prefers for cosmetic concerns, solid thyroid nodules more than 3 cm. Please note that cut-off size for excision is 4 cm because it has a malignancy risk of 30%. For nodules showing significant growth, sonographic features favoring a malignant nodule such as microcalcification, intranodular vascularity, and ill-defined margins. What should be done if atypia of undetermined significance persists after 3 to 6 months. Cases with diagnosis of atypia of undetermined significance are usually recommended to have repeat FNA in 3 to 6 months, with an optional ancillary molecular testing such as point mutations in BRAF and gene rearrangements in red PTC. In most cases, a repeat FNA results in a more definitive interpretation. Only a minority, 20 to 25% of nodules are repeatedly atypia of undetermined significance. The patients are managed based on the results of repeat FNA, ultrasonography findings, and other ancillary tests if available. If the repeat FNA is still atypia of undetermined significance, usually lobectomy is recommended if clinically indicated. To minimize overuse of this category, the reporting rates for this category are expected to be between 2 to 7%. What should be done for suspicious for follicular thyroid neoplasms? The main limitation of FNAC is the differentiation of benign from malignant follicular neoplasm. The next recommended step after FNA includes diagnostic lobectomy or hemithyroidectomy to assess capsular and vascular invasion to reach to the definitive diagnosis, that is adenoma versus carcinoma, before completion thyroidectomy. We repeat, in other words, the final diagnosis depends upon lobectomy because capsular invasion and or vascular invasion are the only diagnostic criteria of follicular carcinoma, which is not a possibility with FNAC techniques. Patients with suspicious for a follicular neoplasm and suspicious for HÜRTHLE neoplasm are not candidates for frozen sections, as I mentioned earlier. Differential diagnosis of follicular neoplasm include follicular adenomas 35% to 50%, follicular carcinoma 15% to 30%, hyperplastic nodules 35%. I emphasize that capsular invasion and or vascular invasions are the only diagnostic criteria of follicular carcinoma. Here we can see a green circle. We consider it as a capsule, and we see the follicular neoplasm infiltrating the capsule, the whole thickness of the capsule. It is called transgression. In this here, with this we can see the capsule here, and this is the capsule and the follicular neoplasm infiltrating the capsule, transgressive infiltration or invasion. Here we can see vascular invasion. These are the only diagnostic criteria of follicular carcinoma. What does suspicious for malignancy mean for surgeons? It means patients with these borderline lesions, BETHESDA category 5, are candidates for a diagnostic lobectomy or hemithyroidectomy with frozen section and a possible completion thyroidectomy at a single surgical procedure. Suspicious for papillary thyroid carcinoma. Cytologically, the pattern of papillary carcinoma can be mimicked by hyalinizing trabecular neoplasm, chronic lymphocytic HASHIMOTO'S thyroiditis, cystic degenerative changes, radioiodine treatment, carbimazole treatment. Ancillary serologic or immunohistochemical studies are of little value for patients with an FNA diagnosis of suspicious for papillary carcinoma. This is the most important. Suspicious for medullary thyroid carcinoma. It needs correlation with serum calcitonin level, because parafollicular cells or C cells secrete calcitonin. Normal reference range less than 10 picogram per milliliter, and all reaspiration for immunohistochemical studies using chromogranin and or synaptophysin, as it is a neuroendocrine tumor. Basal calcitonin levels are high in most patients with sporadic medullary thyroid carcinoma, but normal in 30% of those with familiar or multiple endocrine neoplasia type 2. Basal levels of more than 100 picogram per milliliter have been found to have 100% positive predictive value for medullary thyroid carcinoma. Red gene analysis, that is DNA testing, is a diagnostic method in familial cases. An elevated serum calcitonin level and strong immune reactivity for chromogranin and or synaptophysin can convert an initial diagnosis of suspicious for medullary thyroid carcinoma into a conclusively malignant interpretation. After curative surgery for medullary thyroid carcinoma, serum calcitonin level fall to undetectable level over several weeks. Persistent in high serum calcitonin level after the curative surgery indicates residual cancer either from local lymph node or distant metastasis. Medullary carcinoma of the thyroid does not accumulate radioiodine, so that radionuclide imaging using radioiodine, that is radioiodine CT scan, is not helpful to detect metastasis. Prophylactic thyroidectomy is indicated for patients who carry mutations, red gene in men too, that put them at risk for aggressive medullary thyroid carcinoma. Suspicious for lymphoma. A repeat FNA to obtain neoplastic cells for immunophenotyping studies by flow cytometry is likely to provide a definite diagnosis of malignant lymphoma for patients with an initial suspicious for lymphoma interpretation. In summary, Ancillary testing such as immunohistochemical analysis and flow cytometry in borderline cases is usually more helpful with medullary carcinoma and lymphoma than with papillary thyroid cancer. It is very important to remember that according to American Thyroid Association recommendations, 2015 clinical and sonographic features, patient preference, visibility, and reflexive molecular testing, if available, should be considered in clinical decision making of cases with a diagnosis of ATYPIA of undetermined significance or suspicious for neoplasm categories, that is, nodules with indeterminate cytology. Indications of thyroidectomy: Iowa Head and Neck Protocols, University of Iowa Healthcare. FNA or prior biopsy diagnosis of malignant tumor, suspicious for a follicular neoplasm, suspicious for malignancy, vocal cord paralysis with an associated thyroid mass, palpable fixation of a thyroid mass to surrounding tissues in cases of anaplastic carcinoma or lymphoma, single solid nodule greater than 3 cm, cut-off size for excision is 4 cm, 30% chance of malignancy, persistent reaccumulation of an apparent cystic mass despite aspiration or persistent aspiration of blood from an apparently cystic mass. Compressive symptoms of airway or esophagus associated with the thyroid mass or goiter, rapid growth of a solid thyroid mass, toxic nodular goiter, relative indications and not an absolute indication for thyroidectomy, including patient desire for aesthetic reasons and regardless of presumed pathology, a nodule present with a prior history of radiation to the neck strongly suggests an aggressive course of treatment. The finding of metastatic thyroid disease in neck nodes without an obvious thyroid mass. What should the surgeon do for a suspicious nodule or ATYPIA of undetermined significance on top of Hashimoto's thyroiditis? Diagnostic lobectomy or total thyroidectomy, and why? This case is for total thyroidectomy and not for diagnostic lobectomy because the thyroid gland is non-functioning, so that it is not necessary to preserve a functionless lobe, avoiding unnecessary follow-up. Hashimoto's thyroiditis has a high risk to develop malignancy. It is associated with carcinoma in 3 to 15% and with lymphoma in 2 to 3% of cases. The malignancy risk of the suspicious nodule itself. It might be associated with other clinical radiologic features such as compressive, obstructive symptoms, disfigurement, cosmetic reasons, and microcalcification. Hyperplastic nodule. Hyperplastic HÜRTHLE nodule. It occurs in Hashimoto's thyroiditis and multinodular goiter and mimic a HÜRTHLE neoplasm. In a patient with a history of Hashimoto thyroiditis or multinodular goiter, a nodule composed exclusively of HÜRTHLE cells without prominent nucleoli is more likely to represent a hyperplasia of HÜRTHLE cells rather than a suspicious for HÜRTHLE cell neoplasm. I repeat, in other words, a significant proportion of suspicious for a HÜRTHLE cell neoplasm, 16% to 25%, prove not to be a neoplasms, but rather hyperplastic proliferations of HÜRTHLE cells in nodular goiter or lymphocytic thyroiditis. It can be downgraded to ATYPIA of undetermined significance, category 3, instead of category 4, suspicious for HÜRTHLE cell neoplasm, with an explanatory note. In a minority of cases, this distinction may be hard to make, and a distinctive and definitive classification may depend on histologic examination. Further outpatient care. After total thyroidectomy, patients undergo radioiodine scanning, that is radioiodine scent scan, to detect regional or distant metastatic disease, followed by radioablation of any residual disease found. Annual radioiodine scan is recommended to monitor for long-term recurrence of disease. Patients are given thyroid replacement therapy with T3 or T4. Thyroglobulin levels may also be used to monitor for recurrence of disease, but only if a total thyroidectomy has been performed. In patients with medullary thyroid cancer, calcitonin levels may be used to monitor for recurrence. Polymerase chain reaction assay for germ cell mutations in red proto-oncogene for diagnosis of familial medullary thyroid carcinoma. Late mortality caused by unmonitored recurrence of disease is tragic. Therefore, primary care physicians should be diligent in maintaining long-term follow-up care. Summary. Thyroid nodules are prevalent and either benign 90% or malignant 10%. Thyroid FNA-C is a screening test for the initial evaluation of thyroid nodules and a triage for further investigations. Each category of the BETHESDA system is linked to a malignancy risk and has a recommended clinical management. Benign follicular nodules on cytology are not always benign. That is 0 to 3% are malignant and should be followed up clinically, supplemented by ultrasound, and lobectomy should be considered when there are abnormalities. Indeterminate thyroid nodules include ATYPIA of undetermined significance, suspicious for follicular or HÜRTHLE cell neoplasm, and suspicious for malignancy results. The main limitation of FNA-C is the differentiation of benign from malignant follicular neoplasms. Patients with suspicious for malignancies are candidates for diagnostic lobectomy or hemithyroidectomy at the time of frozen sections with the possibility of completion thyroidectomy in a single surgical procedure. Patients with suspicious for a follicular neoplasm and suspicious for HÜRTHLE cell neoplasm are not candidates for frozen sections. Patients with ATYPIA of undetermined significance and suspicious thyroid nodules, indeterminate nodules on top of HASHIMOTO'S thyroiditis are at high risk of malignancy and are candidates for total thyroidectomy without diagnostic lobectomy. Patients with suspicions for medullary carcinoma need investigations for neuroendocrine markers, for example, chromogranin and serum calcitonin level without diagnostic lobectomy for the final diagnosis of medullary carcinoma. Patients with suspicions for lymphoma need immunohistochemical and flow cytometric studies for final diagnosis. Use of diagnostic imaging modalities does not allow accurate prediction of the histology of the thyroid nodules. These are the references. Thank you.